we start? All right, we're back. This is Senate Health and Welfare. It's still February 18th. And now we're moving on to S-197, our primary care payment reform bill or alternative payment. I don't know what we'll call it, but it's primary care. And it's critical bill, I think, for us to move forward on healthcare reform. And just FYI for the committee, we're going to be spending quite a bit of time getting some good testimony, beginning with Dr. Elliot Fisher today. We're going to spend some time on the bill and mark up with our ledge council. So thank you for coming in and welcome. So why don't you introduce yourself for the record? And
sure.
Love to hear your testimony.
Thank you so much. I'm Elliot Fisher. I'm a professor at Dartmouth. I'm a former primary care physician at the VA hospital for 20 years. When I was such a treat to take care of the really needed care. And I learned so much from it. So first, thank you for inviting me to be here. It is actually an amazing experience to get to drive here through Vermont and see that what a wonderful place we live. And I think the luck that I have is that I got to drive here. I have a car, and many of my patients did. Yeah, and I have great care. Actually, but I can get in something.
So I've got this fan thing going on back here.
That will be very helpful. Just shout.
Anyway, they're not young anymore.
I had to replace the battery in my hearing aids just a second ago. We're on the same page. So it really is a treat to be here. The drive is beautiful. I feel very lucky to have a car to get up here. I have children who have health care. And have a house over their head, and we have so many Vermonters now who are suffering more. And I think that doing something about primary care could be really powerful as a way of helping everybody feel that they're part of this wonderful place that we live in, and at least a piece of it. They have just as good access as everybody else, which I think this vision is that we have, just sad. Maybe the sport mates, the meetings being live streaming, okay, I'll get it with you. Why is this not? Maybe it's different cheating. Now it's not advanced. Okay, all right, there we are. Now we're good. So imagine, you get advice about a health concern any time of day. From someone that knows you, knows what that louder.
It's okay. I'm just wrapping my head.
I used to be an attorney. From someone who knows you, and they could help you with most of your problems, and they can coordinate your care in what's an increasingly wild world of healthcare. Those were the 4 C's of primary care invented by Barbara Starkin many years before. She published this book. Probably didn't, but I don't know if you can see it. But the current path is not great. We've heard from several people who testified that we're in real trouble. We all know from our colleagues and friends that access is getting worse. As are the capabilities of primary care practices to coordinate care, help you find the right specialist, or to help you decide how to manage specialists there. Burnout and moral injury are pervasive, but probably even more so in primary care than elsewhere, because it's so hard to do that work. And consequently, the primary care workforce is declining. We've seen the graphs that Dr. Zuri Sloan presented early in the testimony. He also pointed to a really important observation that, better models are emerging in the private sector. They're pretty nifty. The notion of direct primary care, having access to someone 24 hours a day, or these are very promising ideas that we should be thinking about and learning about. They're wonderful for clinicians. We know that docs who work in them have less burnout, they're having fun. It's like reinvigorating again. And the patients with the means to sign up really feel wonderfully treated within those programs. Unfortunately, you have to pay for those. Usually out of pocket. The private insurance continues. And as a consequence, they're undermining access and care for everyone else. And I think it's one of the sort of headlights that, the tunnel that we're in, the train coming at us could be the complete, the further collapse of primary care, direct primary care, the concierge medicine really take off, pull people out of primary care practice, and they don't want to go back to. So we're facing some challenges. This is the most recent report from the Milbank Fund. No one can see the access is really. Please, let me to special. One of you guys, you should all feel free to if you have questions. So there is a better path. It was recommended, a few years ago by the National Academy of Medicine. And it had the following principles: make primary care available to everybody. Pay more because it's underfunded right now, and pay differently in ways that can really provide flexibility to the practice, security about cash flow, and the flexibility to hire the kind of people who your practice really needs. A health code, then you can't bill for those. You're funding the bill codes and proof of service. So we move through different payment models. Support team-based care, advance the primary care, go back to that, expand the workforce, and take advantage of digital tools and technology, especially when you get that flexibility in the payment model that enables you not to do things that, set up a website or whatever that you wouldn't otherwise be able to build for. And then the italics I put part of the National Academy of Medicine calls for that I think we're not thinking enough about. Put in place a plan for anti-addiction. S197 had, go ahead, that next slide probably. Oh, let me just pause for a second. Where's Vermont now? I think we are clearly motivated to act by what's really a broader crisis. It's not just a crisis of primary care. As we look at what happens when the exchanges shrink or the Medicaid cuts coverage, the healthy people pull out of the insurance markets, leaving sicker paid patients in those markets, costs go up and starts an insurance death spiral. But I think talk to people in the chambers and elsewhere, they're seeing in their communities an economic death spiral. Young people are speaking with their feet, talking with their feet and moving out of state. Businesses are hesitant to move here given the tax burden we face and the costs of health. I got back into this last year, as I told you last year. What? We're the most expensive health in the country on my watch. How did that happen? I wasn't paying attention. I'm so embarrassed. I think the current bill has lots of those key elements, and government really remarkable. I say that one thing, sorry, I didn't get so big. Government has set the table for us to reverse this in the country. I think there are a number of ways that we should see. We have many of the tools we need. We have strong state agencies that are in position and service models. What has been created here in terms of an operational infrastructure for care transformation, the blueprint with SASH and what's going on now in terms of hospital regionalization positions us for really being able to do much, much better. Because there are good reasons to think that we could achieve savings. I'll come back to that in a second. But we also, thanks to your legislation last year, have an even stronger Green Mountain Care Board, which many people find it pain in the neck. I totally get it. It's hard. My friends who run hospitals, Dr. Fisher, you're nuts. What did you do? I'm sorry, they blame you. So they don't blame you.
Okay, we're used to it.
So we have powerful regulatory authority, which I think will give us a tool here to make this possible. New investments from the federal government, which surprised us all, the Rural Health Transformation Fund, but these are both time limited and they don't apply everywhere in the state. Our most populous community doesn't get to have that investment take place there. But I think the most exciting thing to me, and that's why I have that top thing at the top, it says an optimist and policy nerd. I sense an openness to meaningful change in places that could not have perceived a year ago. It's just up with Blue Cross Blue Shield. I talk to people in hospitals, in leadership in hospitals. I'm, if we act wisely, I think we could reverse the primary care death spiral through the virtuous cycle. So here's the slide I want you to ask questions on if I'm confusing. Because this has become for me an anchor how I think about the opportunity we have in Vermont. And it's not a short term, but we work with colleagues at MRT who develop a very fancy computer model on the same kinds of models that are used for climate change to test policy interventions or policy steps that could be taken and see what would happen, understand better what would happen over 25 years. But the model also gives outputs and you can think about them in more short-term periods. But it allows, we scaled down the United States to a place called Anytown, USA. It's just the United States. We've also at the Ripple Foundation where I live, where I work. We have models that we customize for different states. But there are a few elements of the model that we walk you through them and why it's worth holding this in mind as we think about designing an implementation plan. First thing the model suggests that you do for, those who played with it is really make two investments, early investments with a small innovation fund. One is improving care delivery. Second is something that's free. You guys get to do it. It's payment form. And then you try to do some of the public health things that help people become healthy. Encourage people to stop smoking, support smoking cessation. For example, maybe tax sugar sweetened beverages, those would be the other kinds of proven public health initiatives that do lead to those arrows that go off to all of our rights. I assume we're all looking at the same thing, which is to improve health. And they reduce utilization. From the best evidence, this is all based on literature reviews of all the great. So what can you do if you do that? You can capture and share and reinvest some of these savings. That's a key step in the model. It turbocharges everything. It allows you to bring the money into an innovation fund. And then because doing these things initially is kind of expensive, you can't afford to do all the care delivery improvement right away because you actually, even with the innovation fund that we gave these folks in the model, which is 1% per capita, you can only do 27% of what happens. That you would want to do to strengthen primary care. So the innovation fund can reinvest and make sure that you can implement all of these things that we know work to improve care and improve health and create that virtuous cycle. So you can imagine it going around to improving health, reducing utilization, capturing insurance more, and improving care delivery, payment reform further. Get all the public health stuff paid for. And then, as the model is very clear that you have to delay some of this work. But the thing that really improves life expectancy over the long term, it's almost trite in policy literature. Pay attention to the social determinants of health. Those are expensive interventions. Adult education, early childhood education. Provide early child care. Come back to that. But then you can afford to invest in the things that are going to make Vermont thrive over 25 years, of course. And what the model predicts, and this is my favorite, this is just me surprising, but a 20% reduction over that time period in the prevalence of chronic disease. Well, that lowers healthcare costs on a per capita basis. If there's less cost, which is taking out some of the low waste stuff in the healthcare system. That third number is by far the largest number in terms of billions of dollars. That's a 10% increase in state GDP or in community GDP. And the fraction of the population that's poor declines dramatically because people now are healthy enough to work and healthy enough later in life not to develop disabilities that cause dementia. It reduces nursing home costs. So sort of seeing ourselves trying to build that kind of a system of self-sustaining investments could be financially affordable if we thoughtfully about how we implement it. So I think the three major choices that you guys face, do nothing. That's the current path. I think that's neither wise or correct. Yeah, I'm not, I won't.
We're good with
Do you want any questions about this?
let's ask questions about this while we're here. If that makes sense. Coach, can you do that? So I'm reading the fine print down below
Yep.
where payers are investing 50% of their savings into the innovation fund and a 5-year grant established at 1% of local healthcare spending. So can you talk a little bit about the mechanics of how all of that happened and how you brought, how you, general you, brought the payers together to
Well,
do
this
this?
is not, this is, you know, what's Elliot smoking? He comes in, this is what we have to figure out together.
Yeah.
So.
This
it
has
is-
not happened anywhere at this
No,
time.
well, if you look at the, ACOs,
Yes,
where they've worked well,
exactly.
half of the savings go back to the organization, for reimbursement. And half of them go to the payers. We could negotiate a different split for that. And some of it goes to an innovation fund that supports the stuff. Or if you reduce total cost of care, as many of those programs do, then you can afford to invest more from the general fund because healthcare is not as expensive as you project it to be for, does that help a little bit?
Yes, or if RHT were eligible for the entire state, not just a portion of it, it could begin a process that.
RHCP is so important as an investment. Talk to Craig Jones or talk to others about the infrastructure we have and what that gives us. You still have to figure out how to make sure, the whole state gets those benefits. That's ours to figure out.
You can't leave out 20% of the population.
No, we need to, this is about, this is about how we decide to create an innovation fund and how big it is to start with and blah, blah, blah. This is sustainable
So
finance.
as you look at the innovation fund, are you including public and private payers, commercial payers, as well as
Well,
public?
I would put quotation marks around the innovation fund.
Okay,
It's that you would think of the savings we get, and where they sit. And if they're in government, we try to think about, that if we just take them and put them somewhere else and pull away all the things we're investing in, they're starting to create this virtuous cycle and improve care and lower costs and so on. Well, then we're not going to get savings in the future. So this is about the discipline of reinvestment in things that are really going to make a difference. Is that helpful?
yeah, no, I'm triggered a thought in my head.
Great. Other questions? And the 1% innovation fund is just, we were trying to get people to play a simulation. And
So-
said, you don't have all the money in the world forever. You have a grant.
So the
How
other,
you can make it last.
yeah, I mean, another huge question at rest here is, we're all very impatient. And we've been waiting for years to see a reduction in healthcare costs, and we did some of that last year with the bill, and that's going to continue with a decline in rate increase. Then I'm seeing what will happen by the end of 25 years here. And so the concern becomes, how long does it take to actualize this model, evaluate, how do we know it works? And how do we pull people together in a short time?
I was teaching the model last night to a group of mid-career healthcare leaders at Dartmouth who were with us. And what you see when you play with the model, and I think one of your colleagues last year, maybe it was in the house, like give the model and they could play with it. But you start to see savings very quickly. You invest in health and changing people's health behavior.
Well, I guess what I was talking about is how quickly can we put the model in place? That's one thing. Once it's in place, we're going to see savings.
let's figure it. The first
We
thing.
can keep going, but
Yeah, no, our job, our minds, and what we think about what we could do this year that gets us on this path.
yes,
Fine. That is will all.
But we all-
I said it wasn't good enough. So option one is do nothing. I don't think we should do that. I think it's just, you know, I mentioned the concerns about direct primary care, but people are really suffering now. Do something for this. I think whether it's the primary care practices themselves, or the patients who are just, go home from the hospital, fear service. Option two, we can increase investment in primary care and the current payment models. We designed the model for rural advanced primary care. Advanced primary care is a really spiffy way of thinking about delivering care with teams, technology. It's very powerful. I think committing now, and I say we must do this. I think for two reasons. One is committing. We know how to do it. Greg Jones says no big deal. Watch it. He probably wouldn't say that to you because he wants to leave me out here. But we know how to do advanced primary care, not just in rural areas, but all over. And committing now would make many think again about their color independence. I think primary care physicians might be less willing to jump to DPC because they may not direct primary care or concierge because they may not know what the future holds for it. And knowing that they have hope about their current practice might really change some of the dynamics of decision making in the short term. And I think the third option is try to innovate. And you've got this idea in your building, you've heard from people from Massachusetts. And then we cover everything. It gets almost all of the National Academy principles, things advanced care. It couldn't make the advanced care that primary care does to everyone. And it might be great. And I'm really nervous. And many people I talk to with their advocates are nervous about this. So there are financial, technical, and political barriers. What I've tried to do in the next few slides is say, well, how might we overcome this? And so I'll walk you through some one at a time, and you can ask questions. So I think one of the big barriers, and it's one of the things that I believe most strongly about, is that we have very few people who actually know how to improve care or how to improve anything in ways that for healthcare support providers, but hold them accountable and reduce the total cost of care. The lack of knowledge about improvement is that there's sort of confusion in the world of improvement. We think exhortation works, and just tell the primary care doctors to do a better job. Hospitals should be safer. And so what we do is we create dashboards that have red, green, and blue on it. Red is you're not doing a good job. Orange, you're sort of okay. Green is you're doing well. And those are fundamentally for the purposes of embarrassment. You're not doing a good enough job, Elliot. You're red on these three things. I'm on the board of an organization that has red, green, yellow, green. So, but if you look at what's been done in the people who do leave, really what do leave in the way it's supposed to be done, or Peter Provost's work at University Hospitals in Cleveland, what you see is a totally different way of doing this. It's about building systems of improvement and accountability that work, that people know they're being held accountable, but they're being supported to do better. There's a wonderful line, you're not a manager unless you have a run chart. And we support you in learning how to use it. And so he has an accountability system that has all these wonderful features, and he was ready to testify today, but he couldn't do it at the
Understood.
time you guys had. So I
Well,
hope you'll
no,
bring,
he's on my list.
I hope you'll bring him back.
He's on my list.
He's,
Yeah.
so, and we're well positioned with VPQ. We have people trained at the Institute for Health Improvement who really know how to do this, but we have created improvement in Vermont as a hobby. I'm sorry.
Mhm.
The blueprint was set it up. We think we should be doing improvement. And what you get to improve is the choice of the practice. We think we want to do this to improve. And there's no accountability for even we gave you the money to do improvement work, but what did you do? Building it into a system where you can compare yourself to others, you can track improvement on the things that really matter, keeping people healthy and out of the hospital. That will change. It's totally a different way of doing quality work. It's more fun and it's more effective. Any questions about that?
We do have a section in the bill related to quality improvement.
And
It's so critical.
I thought that was
Yeah.
wonderful to see.
Yeah.
And the data that's necessary will make it happen. I hear sneakers behind you. It's a joke. No, I'm teasing you guys. I'm sorry. I'm so old that I have to have fun when I go to circus.
Excuse me, Ted, we're running a little bit
Okay.
late, so I may come to go back in 10 minutes. Is that gonna ruin your schedule?
Absolutely not. I'll be back in 10 minutes.
Thank you.
Yep.
I thought I had to even from 5.
No, you're fine. You've got more time. Don't worry.
So the other thing, talk to people in Vermont right now. I think the other symptom is panic. You know, that bill that you guys put in. How can we do all this at once with so much else on our plates?
Well, didn't we think that last year about the bill we had?
We are still getting, yes, so. And we want to reassure them. But I'd argue for committing now to the long-term goal, make essential new investments, but establishing a realistic timeline and plan for the other elements that we need to do to put in place the system that feeds the long term. I think a big one in some of my conversations is uncertainty about the outcomes of alternative policy approaches, possible harms for whoever it is, for the practitioners, who are running the people who are running the practice. Is there going to be enough money in this thing for me? That's in California. That was a huge problem with their attempt to move to this when they figured out that no, the capitation rate's not going to cover my costs. I'm not in. I'm going to post this. And Mandy, of course, worried that there won't actually be savings. There is a path out of that. The Congressional Budget Office scores bills, and one of my colleagues was in charge of the CBO's scoring for healthcare bills in Congress for a couple of years. They and others and good actuaries can develop a model that will allow you to evaluate the impact of alternative policy combinations and when you put them in place. And my childhood in health policy was with the accountable care organizations. I didn't know how to say that with Vermont, I was having to face them. Not every. But it was the model that allowed us to have that show up, the bill show up, the language show up in the Affordable Care Act, that made ACOs happen, because we had a CBO score. That's saving money. And then it was in every bill thereafter. Bridges to nowhere or whatever. And this is the last part I'll spend a little bit of time on because it's kind of complicated. And it's got a few elements that I want to walk through. But right now we have a decision-making process that leads to less than optimal solutions. We don't know what people care about really. We don't know the things that are really matter to them. We have lack of evidence on the alternative approaches that might be taken to address those. And for the structures of choices for the people who you are asking to change their lives. So I think you need to establish a decision-making process that can bring an action with the proposal to achieve the goals we want and structure the choices effectively. So here's what I'm talking about. So this was developed first used in campaign. I might have mentioned it here last year. I kind of throw these things at you guys, and it's not fair or appropriate. Um, but this is the idea. The first thing is you need to develop a proposal. You need to choose someone who's going to be the process manager and director. At Camp David, it was Cy Vance, with President Carter's help. You let everybody understand how you're going to do this, because the decisions at the end, understanding that there will be a decision at the end, changes how people think about working with you to develop a better decision. Then that process manager and drafters elicit interest of stakeholders. And that is so critically important. It's in private or public conversations, depending upon who the stakeholder is. Some stakeholders won't want to talk to you in public. But once they understand the dynamics of how it might work, the hospitals, the payers that will all join in. The key barrier that you probably run into when someone comes in to talk to you is that they don't necessarily want to tell you, reveal what their absolute bottom line is, because that gives up any influence they have by withholding that support. But you would love them to share what they really care about. And so you don't ask them to commit at any point during this exploratory phase. You develop the first draft of the bill, you take it back around. People go, well, this is terrible here, but this I really like. Someone else may not like that, so you want to understand what their interests are. You go iterate through it, and there were 23 drafts. Now I made higher stakes than the others. Maybe we can get by with 3 or 4. But you redraft until the person who's managing the process says, oh, no, I've talked to everybody. I don't think we can do better than this. And then you ask everybody a different question. So let's go through those. I forgot, there's another bottom to the slide. There we go. Okay. Without the one text, parties push for their positions and withhold key interests, leading to solutions that fail. And final choices, can I get something better later? Let me see if I can kill this and get extended the lines and do something better for me next year. But this scares me because it's wasn't drafted with their interests completely understood. But the final choice is very different. Final choice is this better than nothing? Is this better than what I could get on my own? And if anyone's done their job in that upper half of the slide, it should be a lot better than where we are now. There's some tweaks to this that Congress used for the base closing commission and for free trade. And that's bringing it up for Steve sometimes is getting really upset when people talking about this because it takes away some of the power that the chairs have. And that was one of the challenges for Congress. That's bartering that gets you that deal for the other bill that you want. Anyway, but
Bad people.
Lethal? Did you say?
Bad people.
Yeah. So what I'm asking is your forgiveness just to bring up one vote. If it doesn't pass, then you take it. Take it. So, legislature might consider just doing an up or down vote first. That's what Congress did. Tied its hands, says we'll do it. All right. Might this apply anywhere else? Someone's trying to build up a map of new districts. But the decision becomes for stakeholders and legislators, is this better than nothing this year? Is this starting something better? Yeah, there may be a tax. There may not. I think that we can invent some way of doing this during the design process, the drafting process that will not require a substantial sacrifice or any, but it can work. So that's the part I really wanted to get to. I know it's unusual, but we have examples of doing it. And in many ways, it is kind of what you do anyway. You're trying to do this yourself in the face of lots of competing interests and doing the best you can to get a draft. But I hear where I know primary care practices are scared about will it be good enough. They're scared that it won't be fast enough. They want no co-payments. You talk to a payer and they say no co-payments and they say no go. So, and I think there's a solution to that, but unless it's crafted in a way that we think they might go along with what California does in their exchange plans, you get 3 free visits a year. Get your meds, you get 3 visits, and then it's a $20, pay something, just so that you don't come burn up the primary care physician's practice time. It's also.
But you now have to go 3 visits that you need the 4th one and you're willing to pay for it because it's critical to your health.
Yeah, well, and the barrier should not be the money to get it. It's that if I did this a lot, anyway, this is where we can figure out how to get the economists to agree with the primary care advocates. And it's got to be done in a community so that the public knows. This is why I really emphasize what I think is great about the all alignment process was the public engagement at the same time.
Right. And so, yes, and so as you're talking about this new process, that there are elements of what we do here to establish, to build the actuarial analysis, to have the public engagement, to put people together in the room without, not here, not this room, but another room outside of the session that can bring solid recommendations. And then, of course, there has to be some role for government in this, legislature, because there are state resources and federal resources over we have some.
When I spoke with Bob Ordone, who I mentioned to you, he's an
I've got him on my list.
international expert and he's happy to testify.
Yeah.
And he was very clear that government is exactly one of those stakeholders, that you were one of those stakeholders, that AHS would be one of those stakeholders. Sorry?
Pre-mountain care board,
Of course.
DFR.
Exactly. They're all key stakeholders here. And that's why I labeled them the players.
No, this is really very helpful, and I know that some of the folks that we've been meeting with, you've been meeting with, and have recommendations to come in to help us understand what is a possible next step. How can we go forward? But remembering also that we want to be able to actualize, make something happen.
I hope that we can get. I think we should try to set an absolute clear goal, which you've said in that bill already. Let's cover everyone and let's have universal primary care. The proposal makes, if everybody, well, I think you could get there. Because I hear enough curiosity about wanting to see what's possible from the people I talk to. So I think.
Well, no, that's good. And I think one of the difficulties that we face, kind of the barriers we face, is ourselves. Remember photo, we saw the end. Is if we can't impose on system stakeholders what are good. We need to have that integrated.
Yeah. Well, we want them to want to do.
Yeah. So anyway, this is a good place. I appreciate you're taking the time to come in and help us, and we will have other folks in, some of whom you've mentioned and had on your slides. We will probably have you back in again.
Happy to be as helpful as I can be. You guys have such a hard job. I might count. Chicken thing is really easy.
We have the fun job.
Oh, I have such a fun job.
We have.
I think they'll know how fun my job is.
Any last questions from the committee? We're good. This is great. Thank you.
No questions from you guys? Okay.
All right. Well, we'll get you back in again. So as we better understand.
Yeah.
Yes,
I'll
and-
happily help find other people to talk if you want.
Good.
We've had some good conversations just in the last 2 days.
Thank you.
Also, you have another person to start in.
Right, and
I'll pull out the
we'll
board
be
here.
connecting with Ledge Council on this as well, so it's on one, so we go through 197. So now, we have Ted Barnett, who is not, everybody now the room switches. The next. And Ted, thank you for being here. For 206.
Of course. Yes, it's always been a morning for me where I've been in a bunch of committees that I don't normally get to visit. It's good to be here.
We have your fiscal note on our webpage. I can check that.
Great. So, yes, Ted Barnett, Joint Fiscal Office, here to give a quick run through of the draft fiscal note for S206. Yes, this is the title is in yellow here. Just, I know that there's a vote on the schedule, but if we were to change anything for the vote, this is the draft fiscal note, and it assumes that you all were to vote on the draft that's currently before you. High level, so we'll talk about two pieces, the appropriations, which you all have discussed and I think made changes to as the bill has been in committee, and then talk about fee license revenue once the program is stood up starting in fiscal year 29. So to start with the appropriations, the bill would appropriate $262,000 for 2 positions from the general fund in fiscal year 27. We want to flag, right, there is an appropriation in the bill for fiscal year 27, but in fiscal year 28, there would be funding for these positions because fee revenue would not be available until fiscal year 29. I think you all have addressed this issue, or at least are aware of it because it was in previous drafts. It was in TED language and funding for these positions. So, but wanted to emphasize that piece. And then also additionally reflecting that intent language and also in the OPR Sunrise Review Assessment, they did note that an additional 3 positions above the 2 that are currently in the bill would be needed to stand up full regulation of the profession, and those positions would cost an additional $370,000 annually starting next fiscal year if you aligned position creation and appropriations with what is in that Sunrise Assessment. And fee revenue would not be available until fiscal year 29. So there are some costs up front to getting this board and regulatory system set up. For the fee license revenue, presented it in a table. Before going into the table, do you want to note that the information on this table is we received this information from OPR. The folks at OPR did good work in parsing through reports on the status of the industry and mapping data that is available through those reports to the proposed license structure of early childhood educator 1, 2, and 3. And so, yes, I'm indebted to the good work that they did at OPR, and largely relaying numbers. But I did review the information they provided and then certainly checked out today. So in fiscal year 29, all of the folks who are currently in this profession would need to receive an additional license, and those initial license, they're shown here, scale by $50 from early childhood educator 1 to 2 to 3, starting at $125. And then our family childcare providers at $175. So multiplied by the estimated number of licensees in that fiscal year, you can see that 5,000 estimated positions with that fee structure translates into nearly $800,000 of revenue in that first initial year of licensure, fiscal year 29. And then every 2 years, those licensees would need to renew. And these are biennial licenses, so they're paying every 2 years. And so in fiscal year 31 and every odd year thereafter, you would see about $1.2 million. This is multiplying the estimated number of positions times the renewal fees, which are shown in this column here that I'm mousing over. Some notes, right? This is an estimate, particularly we're looking at fiscal year 31. That number to me seems like Jetson's time, right? Very far in the future. And there are transitional licenses, or not, they're licenses for family childcare providers that they wouldn't be able to receive after January 1 of 29. So over time, you would see a decrease likely in this license type, but at the same time, talking with OPR, they're anticipating an increase in the number of EC, early childhood educators 1, 2, and 3. The profession would increase over time. So hard to know what that wash might be. For now, I'm holding it constant and saying what we're seeing in the beginning in terms of overall numbers in the profession will be somewhere in the ballpark. And thankfully, there's a report in the bill that would report on the number of licensees in each category. So you see around, once we've gotten that initial year, how many folks in the profession would be able to make adjustments if it's seriously out of whack.
Thanks. I've been reading well, been talking as well. So this OPR, you have to renew the fee every 2 years, you said, right? How the fees aren't going to stay stable, though, are they, all the time? They're not. Are they linked to an escalator or anything like so? So how's
So yeah, they're not linked to any sort of inflator in the bill as it's currently in front of you. However,
so would they need to come back to legislature in order to increase the fees through?
Yes.
Yep,
Yeah.
go through the fee bill, go
Okay.
through the fee bill, or it can go through a separate bill like this, and it goes to finance. Finance is the fee place. That's
Okay. Well, thank you.
just to cover the costs.
That's what my concern is. No costs always go up, and so I just wasn't sure if it was if OPR has some authority that I didn't.
We talked the other day, there used to be a regular 3
Yeah.
cycle. That's been interrupted by the present administration.
Yeah.
But when things get behind, OPR is losing money because we've got all these compact licensing. And we know we're going to have to do something about that.
Yeah, because it's
But we don't know
the
what it is.
capacity, right? OPR pretty much selects and sends out. Okay, sorry about that.
No, absolutely. Happy to answer questions that I do in talking with OPR yesterday, right? They're doing a lot of work on evaluating their funding model and are going to come, they have an interim report and will be submitting a full funding, an analysis of their funding model.
And
this upcoming
finance
session.
can,
Yeah, absolutely.
and so can joint fiscal law.
Absolutely. It was one of the first things I did as a JFOer in 2023 was work on the OPR fee bill. Through that year. So it'll be, it'll feel maybe a little familiar.
You'll be back down the hall.
Absolutely.
So questions for Ted on this one. This is helpful to us. We're
Yeah.
wondering how expensive all this is, and obviously having the initial investment is something that appropriations will have to look at and analyze. So we'll see you down there as well. But OPR has asked us for this amount of money to stand up the program. We have shared concerns with them about how quickly that can happen in the economic world that we're in right now. So they are looking at it. Finance and approach will have a good time. See you there.
Thank you for putting that together. That's
Yeah.
really helpful.
Yeah, it's great. It's really good. Are we all set? Thank you.
Of course.
Thanks for your patience and for coming back.
Oh, absolutely. Give me 10 minutes. I talked to a few people in the hall. That's great.
Okay, all right, so now we're gonna work with Katie at both, we'll go to 206 first, Katie, and then we'll go to 243.
We'll see. 206.
206 is the bill.
Yeah.
we're looking at. Okay. Oh, we don't need to go through the bill again. We've been through it. $2,485. And we put in all the changes, and now we've had the fiscal note, which is always at the end. So are there any questions of Kate? I would entertain a motion. Sorry, but-
You have a.
You lost your identity.
I know. Is there?
Yep, she's got.
I saw you.
So I'm entertaining motion for the motion on S 206. What draft?
This is 3.1.
3.1.
I think we make a motion to go favorably on draft 2.1 of 3.1 of S 206. Send it on to full Senate.
That's the motion. Is there discussions? We've had discussion.
A lot of discussion.
We had a lot of discussion. There are a lot of concerns that we have moving forward, some of us, but it seems like what we're hearing predominantly from the profession, to support the changes in the bill.
Ready? Senator Benson. Yes. Senator Cummings.
Yes.
Senator Hewlett.
Yes.
Senator Morley. Yes. Senator Lyons.
Yes.
5-0-0.
Thank you, committee. That's, your work has been good on this, and your questions have helped improve the bill significantly. Really appreciate it. And so the only thing we need is a reporter.
I didn't need me.
Well, it would probably end up being a couple days. And I'm fine. Sure. That would be great. I appreciate that. I just like to towards questions. But you can go into finance and if you go into appropriations. So the reporter, and so you'll get a clean copy and the original bill to go upstairs and, that's great, great. And maybe Calista, it would be helpful. I'd like to have a clean copy as well. So now we can move on to this other little bill. Okay. Congratulations, everyone in the room. You've done really good work and I appreciate your help. Thank you. Thank you very much. Okay, maybe we could close the door. Really on the way out.
We don't have any of those, no coffee, no coffee.
We need one.
It's gonna steal one, and put it outside finance.
Yeah, I know. They do get loud down there too.
Well, when they
It's loud
start
out
the line
here.
out for approach, it gets
Yeah,
really.
Yeah, I know. It gets loud out. So here we are, we're on 243. I think we do need to look at 243 again.
Okay. I didn't say good morning yet. Good morning. Katie McLeod, Office of Legislative Council. Nice to see everyone. Here is, oh, that says introduced. Did you have the amendment to 243? I sent it probably over a week ago now. You know what I'll do, Calista? I'll just pull it up from a Word document. Okay. Thank you. Here we go. So just to refresh your memory, this was the bill about the Vermont Language Justice Project. It had an appropriation of $150,000. That appropriation is still in here. What has been added is a findings section. And a little bit of language has been tweaked as part of the appropriation. So, the new findings section, the General Assembly finds that Vermont ranks 6th per capita in refugee resettlement. Finds that Governor Scott has recognized the important role immigrants play in Vermont's economy. General Assembly finds that when health information is available in only one language and only in written format, it creates barriers that lead to confusion. The General Assembly finds that the Vermont Language Justice Project's videos fill a critical gap in patient education, particularly for families with limited English proficiency. The General Assembly finds that the Vermont Language Justice Project has created and distributed videos pertaining to COVID-19 and COVID-19 testing, the importance of immunizations and how immunizations work, MPOX, preventing mosquito and tick bites, and safety during flood events, hot and cold weather, cyanobacteria outbreaks, wildfires, and more. The General Assembly finds that the Vermont Language Justice Project's videos are made in 10 to 21 of the languages commonly spoken in Vermont in collaboration with the Vermont Department of Health. Finds that the Vermont Language Justice Project is usually able to respond to a crisis within 24 hours with information in multiple languages and in multiple formats, such as written translations, audio files, and videos. And lastly, the General Assembly finds that in January of 2025, the Vermont Language Justice Project's grant from the U.S. Centers of Disease Control and Prevention abruptly ended, leaving it to be funded solely through donations from individuals and foundations through fee-for-service work. So that is the new findings section. Then the appropriation itself is for fiscal year 27, $150,000 is appropriated from GF to the Department of Health for distribution to the Vermont Language Justice Project to prepare informational materials for Vermonters who speak languages other than English in the event of a disease outbreak or other public health emergency, including ongoing personal and public health information. Takes effect July 1, 2026.
So we should get this on our page.
Do you not have it? No. I'm sorry if I didn't send it to you. I thought I did.
I saw everything.
I'll stop sharing and I'll send it to Krista and then I'll pull it back up.
And then once we have it up, can we go through it briefly?
Slower. Sure.
And I know that we're also we have 210, S210, the autopsy bill. If we have time, we'll look at it. And Judiciary hasn't looked at it yet. And I did send a note to Senator Hashim. So I'll make sure that he looks at that because it has superior reporting. The ones other courts what to do.
Okay. Okay. So go through the language again. We have. It'll take a minute. Let's do it again. Do you want me to read through it again or would you like to wait?
As soon as we get it.
Okay.
I don't know what the.
Yeah, no problem.
So the one I'm looking at's not right, then.
If it says bill is introduced, then no.
No. No.
Yes, that's. Happy birthday, Jack. Well, birthday to all. Should be there. Yes, it should be there.
And me, both of us.
Oh, sure.
Yeah, today is the Senator Benson.
Oh, well, February, a very particular. Meeting. Or, well,
He's 39, he said.
yeah.
There's something right down there. So I still don't see it.
I don't have it. No, it's-
Okay, so let's go through it.
You have it. Oh, it's posted. Have you refreshed?
I'll give it, I'll refresh 60.
I'm refreshed many times.
I'm sorry.
It's a 30-minute refresh.
I don't know.
A lot of refresh going.
The extent of my IT expertise.
Yeah,
Let's
right.
go through.
But I'll read more slowly.
Yeah, that would be good.
Okay.
It's on now.
2.1.
Yes.
Okay,
Okay. The General Assembly finds that Vermont ranks 6 per capita in refugee resettlement. Governor Scott has recognized the important role immigrants play in Vermont's economy. When health information is available in only one language and only in written format,
I have a question. Do we ordinarily put the name of a governor or lieutenant governor in the findings, or we simply say the governor or the administration? I don't know.
I don't know that I've ever included the governor. I must have.
Why don't we, or the administration? Or might be in violation of schools.
You could say the governor if you would like to. Would you
I
prefer
think
saying
that's
that?
probably better.
Okay,
You
I can
know,
make that change.
It is Governor Scott who's done that.
PIH has contract with them. So,
With
the, that's
who's. Oh, yeah, Department of Health. Administration. Go ahead.
3, when health information is available in only one language and only in written format, it creates barriers that lead to confusion. The Vermont Language Justice Project's videos fill a critical gap in patient education, particularly for families with limited English proficiency. The Vermont Language Justice Project has created and distributed videos pertaining to COVID-19 and COVID-19 testing, the importance of immunizations and how immunizations work, mpox, preventing mosquito and tick bites, and safety during flood events, hot and cold weather, cyanobacteria, outbreaks, wildfires, and more. Top of page 2. The Vermont Language Justice Project's videos are made in 10 to 21 of the languages commonly spoken in Vermont in collaboration with the Vermont Department of Health. The Vermont Language Justice Project is usually able to respond to a crisis within 24 hours with information in multiple languages and in multiple formats, such as written translations, audio files, and videos. And lastly, in January 2025, the Vermont Language Justice Project's grant from the CDC abruptly ended, leaving it to be funded solely through donations from individuals and foundations and through fee-for-service work. Brings us to section 2, which is the appropriation. For fiscal year 27, $150,000 is appropriated from GF to the Health Department for distribution to the Vermont Language Justice Project to prepare informational videos for Vermonters who speak languages other than English in the event of a disease outbreak or other public health emergency, including ongoing personal and public health information. And we have an effective date of July 1, 2026.
So the biggest part of the change are the findings, which I think is important.
I'll make that.
I understand is that 150 were basically in the reserve fund. It means when if there's an emergency.
No, would go to the Justice Project, and then they would produce communications, whether it's video or audio or both.
Right, but for a health emergency.
Yeah.
So if there's no health emergency, the money's transferred. It sits there until such time that there is a need.
Yeah, it will probably go through the Department of Health, so there'll be some accountability for how it's used. Thing, so that will be a question answered in appropriations.
So,
They straight up. General fund.
Yeah,
Sure.
definitely is.
It's all we're doing.
Yeah.
Yeah, we're saying it's an affordable consideration. The bill will go down there. What usually happens with a bill like this is the money gets stripped out. Then the language goes forward. And then, as the budget's considered, it probably be, I don't know that we'll make it into the budget in the House, but as the budget's considered over here, it'll be considered with everything else. The amount could change, it could be eliminated, just. It'll go forward because there's nothing in the bill for the appropriation. We'll see. Depends, usually if there's any study with a per diem on the wall, and in the end, they divide it up. Well, that could happen with this. I mean, it could sit on the wall in appropriations until we have the budget conversation. Get all the needs and all the money. So the question will go into waterfall. Yeah, all of it, all of the above. Yes, waterfalls,
Big and
trickle this year. Senator Hewlett may never get an opportunity to present it on the floor of the Senate.
Oh, that would be a shame. It's a short, it's a small bill, but it has very huge impact in the state, so I'm hoping that. Thank you, Bill.
So I don't know, questions for Katie, discussion, is this something we want to send down the hall to approach for consideration?
Yes.
Then if you do, then I accept the motion. That's a motion. Why did you say?
I hereby move the draft 2.1.
Because I made the change. Yeah, because we just made this change from Governor Scott to the.
Oh, right.
3.1,
Yeah,
Sorry.
3.1.
Oh, it's three.
Yeah.
I move that we vote favorably on draft 3.1 of S-243 and send it to full Senate. Good. Good.
Okay, that's the motion.
All right,
Any further discussion?
that was with amendment. Favorable with amendment.
Yeah, as amended. Bill said,
Yes, all right.
Mr. Clerk,
Yes.
Senator Clerk.
Senator Benson, yes. Senator Cummings,
Yes.
Senator Hewlett,
Yes.
Senator Morley, yes. Senator Lyons,
Yes.
and I take it you're gonna report this as well.
And you know what? I don't think we could take it away from her.
I would be honored.
She's getting all the good
I know.
bills.
Yeah.
Yeah.
he's hammering.
So somebody, think about whether who wants the autopsy bill.
I know.
Thank you.
Other things coming up. So, and to that end, I am gonna be scheduling our bills very consistently. So that we can get to closure, because we've had a lot of testimony. And do think about which bill you might like to, present. When you vote favorably on a bill, I'd like to know if you want to present the bill, it would be nice. Everyone should be involved. Because we've been involved in the discussion. And as a heads, we're going to do our agenda planning today. And I'm thinking that we will probably meet earlier in the morning, like 8:30 for the next week, and then the week after for crossover. And we'll see how that goes. That's what I'm saying right now. Huh? So the week after next is town meeting week, but the week after that. Okay, so that's it.
2:10.
2:10, do we want to talk about that? Yes. Briefly, we got a few minutes.
Okay.
And then we have a visitor.
Okay.
In about 8 minutes.
Okay. So here is the amendment to S 210 draft 1.2. This is the autopsy reports. And if you remember, there was conversation with Judge Zone, with the health department about getting access to, autopsy reports. If they weren't otherwise allowed to be distributed or, distributed under HIPAA. So this amendment, has been the work of, conversations with Judge Zone, with the health department. The health department asked that the state's attorneys receive notice, so the state's attorneys have weighed in on this. And so I think at this point, what you're seeing is consensus language from those three parties. What this language does, it is not a strike all amendment. It replaces subdivision, I think B2A of or B2 of the bill as introduced, which was the language that created a judicial path to obtaining the autopsy report. And you'll see we have a lot of language in yellow. So those are the changes since you've last seen it. This adds notice requirements. It adds language like a timeline for being able to respond. It adds notice to the state's attorneys. Most noteworthy, it defines what good causes to help judges have parameters for making a decision about when to release the document. So I will go through it with you, but those are sort of the big changes you're seeing.
And they've reached consensus on this. That will make life a lot easier in judiciary.
I have been told that those three parties are in agreement with this language. Each one has
Thank you.
has said that they're okay with this.
Beyond our- Yeah.
Okay. So an individual who is not authorized to receive an autopsy report pursuant to subdivision 1 of this subsection B, meaning under HIPAA, may petition the probate division of the Superior Court for a copy of the autopsy report. The petition shall contain an affidavit attesting to the petitioner's relationship to the decedent and the reason the petitioner is seeking the autopsy report. The petitioner shall notify the office of the chief medical examiner and the state's attorney of the county in which the death occurred within 5 days after filing the petition. The office and the state's attorney shall have an opportunity to respond within 14 days after that notice. If the Superior Court finds that the petitioner has demonstrated good cause for the petitioner to obtain the autopsy report, and the state's attorney does not object, it shall order the office of the chief medical examiner to provide a copy to the petitioner in whole or part. That means it can have the redactions if the court finds that appropriate, and may place restrictions on the petitioner's dissemination of the copy provided. Meaning, I am giving this to you, but you can't distribute it outside. It's for the petitioner themselves and not for other parties. So the court can place that limitation on this language. So
does that imply that the court could say you can read it here, but you can't take it out of the?
possibly,
Okay.
yep.
Makes me feel better, because I think.
Yeah, it makes me feel better.
Page 2, this is our definition. In determining good cause, the Superior Court shall consider the relationship of the petitioner to the decedent and the decedent's family, whether the disclosure is necessary for the public evaluation of governmental performance, the seriousness of intrusion into the decedent and decedent's family's privacy, whether the disclosure is by the least intrusive means available, including whether and to what degree redaction of some portions of the autopsy report is appropriate, and the availability of similar information and other public records regardless of form. That is how the court would balance its decision-making on whether to disclose and the extent to which the disclosure can happen.
I don't remember number 2, V2, whether the disclosure is necessary for the public evaluation of governmental performance.
So when Judge Zoni was here, he referred us to Wyoming statute.
Yeah.
And this was language from Wyoming about governmental performance.
I'm just trying to come up.
Maybe the police didn't do a really good job. There was a bullet wound.
It could be a public safety.
Yeah.
issue.
Okay, I couldn't come up with one of those.
That's what I would take it.
Yeah.
Me
Okay.
too.
It's
Yeah.
probably more full.
Oh, I'm not-
You're planning on voting this?
It's up to you and the committee.
I've got to go to money chair, so
We got 3 minutes.
yeah.
Oh, you gotta go.
A motion for me today.
I can make a motion. I'll move to.
Okay, and I will make sure that Senator Hashim has a close look at this. And that all the parties that are in agreement. Who's making the motion?
I think she did.
Senator Cummings, thank you.
Okay.
Discussion? Questions? We're good? Clerk?
Senator Benson. Yes.
What's love starting at B? Events on the floor and the committee.
First.
I remember someone doing that one time.
Somebody did,
I did hear that,
I think it
but,
was Peru one.
Yeah. Senator Cummings,
Yes.
Senator Gulick,
Yes.
Senator Morley, yes, Senator Lyons.
Yes,
Wow.
You guys are keeping me busy.
we are productive today.
So,
Is there anyone who wants to report this?
no,
Wait,
you're reporting it.
And
it's either you or Senator Morley or Senator Benson.
I can't take it up right now. Leave it.
No,
I'll be with Charlotte, I'll bring it up.
We're good. Excuse me, unless you want to do it, or unless Senator Benson wants. Is there an interest in presenting it? Oh, give them the option.
I'd rather see a few more.
Okay. we're
For-
good. We got it. Understood. This one does not have money in it, so we'll.
Right, this should be easy, yeah.
So,
Be ready. This was.
So Senator Cummings.
Very good.
Okay.
1.2.
She's had judicial experience with, judiciary. committees, so that's- Voila. We are finished. We're not finished. We're finished with the bills. We're going to invite Tess Bettler up to talk with us about Thomas Graduates very briefly.
Thank you for being here. Thank you so much for having me, Madam Chair, members of the committee. My name is Tess Bettler. I'm the Associate Director of Government Affairs for Compass Pathways. I do have hard copies of my testimony if you would like me to distribute those.
Sure.
Absolutely.
Thank you.
Slides. So, again, thank you so much for your time today. Compass Pathways is a biotechnology company dedicated to accelerating patient access to evidence-based innovation in mental health. Our focus is on improving the lives of those who are living with mental health disorders and who do not benefit from existing standards of care. Compass Pathways is conducting the largest FDA-regulated clinical trials ever, studying the safety and tolerability of psilocybin with our lead compound, COMP360. COMP360 is a synthetic pharmaceutical-grade proprietary formulation of psilocybin. COMP360 is manufactured according to FDA-enforced good manufacturing practice standards for quality, consistency, and purity. Phase 3 clinical trials are currently being conducted with COMP360 in treatment-resistant depression. Results of our Phase 2b clinical trial for TRD were published in the New England Journal of Medicine in 2022. For your reference, I have included the results of that study. I believe they're posted online. And the FDA granted breakthrough therapy designation to COMP360 for treatment-resistant depression in 2018. Assuming positive results of these Phase 3 studies, Compass Pathways plans to seek FDA approval for COMP360 as a medication prescribed and administered under the supervision of a licensed healthcare professional in a professional healthcare setting for treatment-resistant depression. And along with our clinical development in TRD, In May 2024, Compass announced positive top-line results from an open-label phase 2 study evaluating the safety and tolerability of COMP360 in post-traumatic stress disorder. Compass plans to pursue further development investigation on COMP360 and PTSD. We are asking for your help to ensure that patients have access to this innovative treatment in the event that it is FDA approved and rescheduled by the Drug Enforcement Administration. The United States is in a mental health crisis, and depression is one of the most common mental health disorders. Depression significantly impacts relationships, work performance, overall quality of life, and is associated with an increased risk of suicide. Major depressive disorder has been ranked the third highest cause of the burden of disease worldwide in 2008 by the World Health Organization, which has projected that this disease will rank first by 2030. An estimated 21 million adults in the United States suffer from major depression, and approximately 9 million are drug treated. Due to the limitations of existing MDD medications, approximately 1/3 of patients with MDD will develop TRD. TRD is broadly defined as an inadequate response to 2 or more appropriate courses of approved medications. TRD has a significantly greater impact on individuals compared to MDD, leading to residual symptoms, poor quality of life, increased comorbidities, higher mortality, and an increased risk of suicide compared to non-treatment resistant MDD. And there are currently only 2 medications approved by the FDA for TRD. PTSD is a serious mental health condition that can develop after exposure to traumatic events, including assault, combat, natural disasters, and serious accidents. It is marked by intrusive memories, avoidance behaviors, negative changes in mood and cognition, and heightened arousal. About 5% of US adults experience PTSD each year. Symptoms may emerge soon after the trauma or be delayed, but they must last longer than a month and disrupt daily functioning to meet diagnostic criteria. PTSD can impact anyone, though certain populations, including veterans, first responders, and survivors of abuse, are at elevated risk. Individuals living with PTSD frequently experience comorbid mental health conditions, most commonly depression, anxiety disorders, substance use disorders, as well as a significantly increased risk of suicide. These overlapping conditions can intensify distress and complicate treatment. Despite affecting roughly 13 million people in the US annually, PTSD remains underserved despite its prevalence. Only 2 FDA-approved medications exist for PTSD. This limited pharmacological landscape underscores the urgent need to advance and expand care for patients experiencing this debilitating condition. PTSD disproportionately affects certain demographics, including women, people from different racial and ethnic backgrounds, and military veterans. Of patients treated for PTSD, only 20 to 30% reach full remission with currently approved pharmacological treatments. All psychedelics, including psilocybin, are currently DEA Schedule I substances, which are defined as drugs with no currently accepted medical use and a high potential for abuse. Schedule I drugs may not be prescribed, dispensed, or administered. However, upon FDA approval of a current Schedule I medication, the DEA is expected to review clinical trial information provided by the company during the new drug application submission and make a federal rescheduling decision. States will need to reschedule the medicine through their defined process to allow the medicine to be prescribed to patients in their state. In Vermont, legislation must be passed to add a drug to the state's regulated drug list, ensuring it can be prescribed. Vermont has done this before. In 2018, the legislature passed a law adding FDA-approved cannabidiol drugs to the state's regulated drug list, which allowed for these drugs to be prescribed and administered in the state upon FDA approval. I have submitted draft language to make a similar change with respect to synthetic psilocybin to my testimony for review and discussion. And in conclusion, this committee has the opportunity to ensure timely access to this innovative treatment, provided the language we have submitted with my testimony is incorporated into legislation currently moving forward. I did also include some sources for various information I'm happy to take.
Terrific, very helpful. I mean, we did have a study committee looking at psilocybin, and I know there's been discussion with the Department of Health for use of psilocybin in certain conditions, end of life. So that you're going through the process.
Yes.
Yeah. Go ahead, Senator.
Thank you, Tess. I appreciate it. I was just, if it's okay, Senator, just very quickly wanted to tell the new folks on our
Please go
committee
ahead.
that in my first session, I had a psilocybin bill in this committee because I really felt this test underscored that we're in the midst of this mental health crisis, and it feels like we're doing a lot of the same things, you know, and I felt like it's time to take some bold action and try something new. we took a lot of testimony a couple years ago from folks who work in the therapeutic realm and use and have used psilocybin in a therapeutic setting, and they shared with us how incredibly impactful it has been on the lives of people, especially those suffering from PTSD, a lot of veterans. So that was where the bill came for the study committee, and they really need more time, which is, there's actually another bill to continue the study committee. I'm just very much in favor of us exploring alternative therapies under the watchful eye of a practitioner and of, you know, a therapist and a doctor. So just wanted to share that it's been in this committee now for a few years.
At least.
Yeah.
And we do have a bill, S-154, a biomarker bill for Alzheimer's that conceivably something about psilocybin could be germinated and go forward. So think about it. We haven't taken S-154 off the wall yet, but I was thinking we might do that. We asked for it from finance, and it's very important to the Alzheimer's Advisory Committee, which has legislators. So there's just a little process that we might think about. Thank you for coming.
Absolutely. Thank you so much for having me. I appreciate it.